My name is Jason Friesen, founder and executive director of Trek Medics International. I'm joined by Tani Cooper, who is our business development manager. And we're here today to share with you about communications technology for crisis response teams. And first, what we'd like to do is start by thanking our partners and supporters. So first to mention is MIT Solve and Stand Together Ventures Lab. We are a member of the Unbundled Policing Accelerator, which is focused on deploying and scaling innovative solutions to reduce adverse interactions between the police and the community. And it's been a real joy being a part of that accelerator, as well as all the other organizations involved. We've also gotten considerable support from PagerDuty, Cisco, Twilio, and Amerisource Bergen to be working in community response and crisis response teams, especially from a technological standpoint. And we've also got solid support from New Relic, who really helps us keep eyes on our technology to make sure that things are running as they should be. So we're just very grateful to all of them for the support that they've provided. The goals of this webinar are first to understand the universal emergency response workflow. As a former paramedic and now as the founder of an organization that works with all sorts of different crisis groups, we oftentimes get asked questions, how is it that you're working with groups that are involved in domestic violence and mental health emergencies that are also involved in opioid overdoses or traditional ambulance services? And the answer is that because we're involved in technology, we actually are doing things from this universal approach, right? It's not like you call 911 for a car accident and 912 for domestic violence and 913 for pregnancy. The reality is that you call 911 for all emergencies. What changes is what people do when they get on scene, right? So the actual logistics and coordination of getting responders to an emergency or a crisis is pretty universal, and we're going to go over that workflow. But what changes is when they get on scene, and that oftentimes has very little to do with technology. So we'll go over that first. And then we'll talk about the common elements of different crisis response teams. What do they all have in common, and what can be applicable to your crisis response team? And then the 6 questions needed to determine the communications technology or technologies that your crisis response program would need. So a kind of how-to template approach to setting up your own technology. Well, next we'll be talking about how these concepts can be used to design and launch structured response networks. And then finally, questions and answers, again, time permitting. If we do run out of time and you do have questions, you can always send us an email at info@trekmedics.org. So a little bit about Trek Medics. Our mission is to improve access to emergency care around the globe through life-saving technologies. And what that means is we're trying to build technologies and solutions and use other technologies to bring them in together so that communities can send the right responder to the right call at the right time, every time. And the values that we're bringing is that we have a lot of experience. Not only myself as a former paramedic, but also Tani has been working in social service, in community organizing, in opioid overdoses and harm reduction. We have other members who are involved in EMS, security, safety, have been working in NGOs and healthcare delivery around the globe. So we've got a lot of experience under our belt. We're also focused on impact. We want to see that these systems work and that they're making a difference in everyday lives. We are a nonprofit organization, and we're very much focused on getting results and impact. We're also very much focused on accessibility. We want to make sure that these technologies can be accessed by all sorts of groups and teams, particularly at-risk and vulnerable populations. We've got a lot of emphasis on accessibility as well as reliability, above all, making sure that the tools and technologies are always available and that they can be used without interruption. Our experience is that we started out working with formal response services, particularly emergency medical services, as you can see, fire departments, disaster response, and some of our biggest partners and the ones that we've had most experience with are the International Committee of the Red Cross, World Bank, the US Coast Guard. SFERI is an organization in Puerto Rico that's been doing a lot in rural Puerto Rico to improve access to emergency medical services, particularly during disasters and hurricanes. Impact Northwest is another organization we've got a lot of proud experience working with. In fact, some of our team is in Belize right now with Impact, working on a program with the Belize National Fire Department. But we've also been involved in a lot of alternative response services, and we're going to talk about those today, particularly substance abuse with the Connecticut Harm Reduction Alliance, domestic violence with SafeNest, behavioral health, the Telecare Corporation in San Diego. We've also done programs in COVID-19 and in community paramedicine. So, you know, as I said before, we're kind of all over the map, but the reality is that we can do this because there is a universal approach to responding to emergencies. What we've learned along the way is that new crisis response teams have a tendency to misplace the focus of their operations by emphasizing features and not functionality. And what do I mean by features? Well, I typically am referring to one feature in particular, and that's what we would call the intervention. What do they do when they get on scene? All sorts of crisis response teams are very much focused on what they do when they get on scene, but they kind of overlook all the other things. And as you can see here, there is a workflow that happens for all emergency response. The stages of this workflow are first access. How is help requested? How do people call for help? Then is call handling. When that person calls for help, who are they connected to? And when they get connected to someone, presumably a dispatcher, then there are a few steps that need to happen there. First, the needs need to be identified. So the caller has to be interrogated. Then after that, once they find out what the needs are, then the dispatcher has to determine what are the appropriate resources. And then finally, once they've decided what appropriate resources are needed, then they need to alert and assign those resources, and that's their dispatch. So after call handling has happened, now it's about the response stage. So this is when resources are coordinated, when they get on scene, and then once they're on scene, what is the intervention? What help is delivered? And then finally, once help has been delivered, the intervention is completed, then there's some sort of resolution or the overall objective has been met. So if you look at this from another kind of functionality standpoint, you're actually talking about two separate areas of function. One is managing demand, right? Demand is people who need help. The second part is managing supply, the people who can bring help to the people who need it. And this brings together the emergency response workflow. So if we're talking about features and functionality, a feature, as we're defining it, is a tool that's needed to complete a task. The functionality is how all of those features work together. And so if we look at all of those features separately and bring them all together, you can see how supply and demand are managed. Now, more practically speaking, here's an example of emergency medical services, right? Your ambulance services. In this case, let's say that demand is someone who is in a motor vehicle collision. So they would call through access to a dispatcher. The dispatcher would interrogate them, figure out what's needed, and then dispatch resources in an ambulance. The intervention is stabilization, and resolution in this case is bringing the patient to a trauma center. Another example would be hurricane response. In this case, the person that needs help, the demand is a stranded victim. So they're calling and a dispatcher answers, and the resources to get to this stranded person would be, in this example, an outboard motor. Once they've gotten on scene, the intervention is rescue. And then the resolution is getting that victim to refuge. So these are your traditional response services that you can see they follow the same model. But we're talking about crisis response teams here, which are often considered alternative response services. So let's talk about substance abuse. And this is going to be one of our guest speakers today from the Connecticut Harm Reduction Alliance. What they're involved in is opioid overdoses. So when there's an active opioid overdose, someone calls CTHRA up, the dispatcher answers, gets the information, and then the response is street outreach workers. The intervention is Narcan, which is also known as the antidote to overdoses. So they get on scene, they administer Narcan, that reverses the overdose, and then the resolution is some type of continuing care, right? Whether they bring them to the hospital or they get them into treatment or detox or referral services to deal with the addiction. There are a number of different resolutions in this case, but you can see the initial intervention is Narcan. And then after that is figuring out where the resolution will be, depending on the victim. Another guest that we're going to have is Telecare Corporation in San Diego, and they're involved in mental health crises. So in this case, access is from a person with a mental health crisis. They speak to a dispatcher. The dispatcher sends out crisis counselors who can provide some type of counseling or support services on scene. The resolution is Stacy's, right? Some kind of equilibrium, getting them back to a manageable state. In domestic violence, which is our other guest from SafeNest in Las Vegas, in their case, the victim is a victim of domestic violence who will call up a dispatcher seeking assistance. An advocate will be sent out. When the advocate gets on scene, they provide some sort of support, access to other services or advocacy. And in their case, the resolution is a safe environment to get them out of harm's way and away from the perpetrator. So you can see it's the same emergency response workflow. It's just the features change a little different in each case, but the functionality is still the same. They are managing demand and supply. And so now we'll talk about an assessment. How do you figure out what technology you need for your crisis response program? And we're going to do this by having each of those guests talk a little bit about their own programs. And we just want to go through those same questions, the questions about each of those features and how they all work together to manage supply and demand. And the 6 questions we're going to talk about is first, the scope. And these are questions that you can use for your crisis response team to figure out what technology you're going to need. So the first is scope. What types of crises do you respond to? Then access. How do people who need help call for help? Next is call handling. How are incoming calls managed? Then response. How are your responders coordinated? After that, the intervention. How are responses documented? And again, we're talking about technology here. So when it comes to the intervention, we're talking about how do you document the intervention, not specifically what the intervention is. And then finally, how do you know when the final objective is met? First, we're going to be talking with SafeNest. SafeNest is based in Las Vegas, and we have with us today Jennifer Espinal, who is the Director of Crisis Support.
Hello.
Thank you very much. It's a pleasure to have you. Your program is, we cannot say enough things about what you're doing. It is so impressive, and I'm wondering if you could just share a little bit about it. First, the scope. Who is it that you are providing support to?
So we provide support for victims of domestic violence as well as sexual assault.
Okay, and who qualifies? Who is it that calls for assistance?
Anyone that's pretty much in need, that reaches out, even if, let's say, they don't necessarily are not exactly going through domestic violence at the time. Like, we provide services to everybody, or we get them connected with other agencies that might be able to help them with those resources if it's not something that we're able to provide.
Excellent. So do they call you directly? Do they call 911? How do they call for help?
So it's both. We have people that will call us directly. They will call into our hotline, and they will also call into Metro. So it really just kind of depends on what the situation is. There isn't one way that people will reach out. So if they call in through Metro, of course, we'll go ahead and get the information either through dispatch or our Metro officers. And sometimes they'll call us directly, and that might lead to the opposite way, where we may have to go ahead and get them on the line with Metro officers at the same time that we are triaging that.
Okay, that's fantastic. So walk us through it. How does it happen when it comes through Metro Police?
Okay, so when they go ahead and get a domestic violence call, officers are out on scene, they'll go ahead and make the assessment, where then they'll go over the air and they will reach out to dispatch. And dispatch will go ahead and then contact my hotline advocates if they are needing an advocate out on scene. Now, sometimes officers will actually call us directly as well. Either way is perfectly fine.
And do they ever show up on scene when police is not there?
No. That is something officers for our program have to be on scene in order for us to have an advocate there.
Okay, so you have specific protocols when you will send them out and when you don't.
Absolutely.
Excellent. And so how many advocates do you currently have on your roster?
So we've got about 13 paid advocates, and we've got about, I want to say about 60 volunteers that we dispatch out.
And when someone calls into SafeNest, either police or they call directly, how do you decide who's going to go with so many responders?
So there is a sign up. So of course, our advocates they're working, they're scheduled. So they are always available. Our volunteers, they sign up for shifts. And we do go ahead and dispatch out our volunteers first. We have through the Beacon app, we have them assigned to different area commands on where they're located because they dispatch from home. So on their shift, they might be in the Northwest, let's say, area. And if we get a call that comes in from over there, to make sure that we are cutting down that response time for an ETA for our officers, we will dispatch out the closest advocate available.
And this is from your call center?
Yes.
Excellent. Okay, so you will pick specific responders to go. You know exactly who is on shift and who needs to go.
Absolutely. So like I said, our volunteers dispatch from home, and we have them when they are logged in, they have a tag listed in what area they are in Las Vegas. And so we're able, when we take the calls from dispatch or from an officer, we get what area command they are in. This way it better helps us triage which advocate we can send out to them that is in the closest area.
So you break it down by geography to get someone there, whoever's closest. Do you have specific times that you're trying to get them on scene?
We try for a 20-minute response. Our office is pretty much centrally located. So it usually takes about 20 minutes, give or take. Of course, this is having to take into consideration with rush hour traffic and stuff, but it definitely has helped with our volunteers that are in, with them dispatching from home, they're already in those different area commands. So that response time has definitely cut down quite a bit.
So the goal is 20 minutes, but you're definitely shooting for below that as often as possible.
Absolutely.
And did you decide 20 minutes or was that police? How did you come to the 20-minute goal?
It's usually about 20 minutes, give or take, to get to these different areas is what we just kind of were able to assess when we launched the program and we were looking at what our response times were. So it was definitely something that we were tracking to go ahead and see. And then at the same time, it's to go ahead and the easiest way is to go ahead and we're trying to cut out from, if officers get a priority call, we definitely want to just make sure that we're able to meet the victims where they're at. And we know that just kind of with everything that's going on, different things happen. And this also helps for, our clients that, they can get nervous. Right. And of course, the sooner we can get someone there, the easier it is not only for officers, but for our victims.
Right. So you send out one of your advocates at a time and they're on scene with a police officer. And what do they do when they get on scene? What are they providing?
So really we're meeting the victims where they're at. So it's we're finding out basically when our advocates get on scene, first we're meeting with officers to kind of see what happened. Was there an arrest made? And if there is, then we're going to go ahead and we have a little bit better of an idea of some services that we may go ahead and provide. And then when we're meeting with the clients, it might go ahead and we're seeing what it is that they're needing. Are they looking for counseling? Are they looking to get an emergency protection order, which is something that our agency does when there's an arrest made? If there wasn't an arrest made, maybe the perpetrator fled the scene. We also go ahead and we'll help them do a temporary protection order. Are they looking for shelter? Are they looking, do they have an open case in the courts right now? We have our different departments that work in for civil court. If they are having, again, to do the protection order, they're going through divorce, they're going through custody, or there might be a preliminary hearing that they already have going on in our justice court. So we're just kind of finding out what it is that our victims are looking for. These are services that we provide. And to be honest, sometimes because we are meeting them in that moment of trauma, it might be a lot to process and they might not know what it is that they want. And in that case, we have a SPAL card that we provide so that they know that they can call our hotline 24 hours a day, 7 days a week. And my advocates will provide the same services by phone if they're unsure, if they want to do anything at that moment, or, you know, other things are going on and they might be trying to get their children settled. So they may want to give us a call later. And so, you know, again, it's just meeting our clients where they're at and what their needs are. And if it's not at that moment, then, you know, we're able to meet those needs even after.
Right. So in this case, resolution can come in all sorts of different ways.
Yes.
There's not one, we take them to a shelter and wrap it up. This can be an ongoing thing.
Absolutely. This also kind of coincides too with sometimes our advocates can go on scene and based off of the injuries, they might be getting transported to the hospital. So of course, if they're meeting with detectives, if they are getting transported, you know, by EMTs, what we'll go ahead and do is from that point, we might have another call. So maybe that advocate is dispatched out to another call, but what we will do is the social workers at the hospitals, officers that accompany them can give us a call when we do have access to our clients, and we will dispatch out another advocate, even if it's hours later, to go in person to the hospitals and sit down and talk with them.
Incredible work you're doing. Can you just, one last question, how many responses do you have on average per day, per week, per month?
Gosh, that is kind of a hard one to go and say. I would say last month for February, I want to say it was about 3,000 and like 515 responses.
That's a huge number.
Yes, that need is very great.
And currently you're in Las Vegas. Are there, I mean, this sounds like a program that could be used in many locations. Are there any plans for scaling?
We are right now. We provide services to Clark County, and possibly we may be expanding out. There's always a possibility for North Las Vegas as well as Henderson. It's definitely gotten around enough, and it definitely helps out officers to put an advocate, you know, at the time of that trauma and getting those services, and even if they're not utilizing it at that moment, it still plants that seed that there are those services for them. And if it's their children, for some people, it might be family members that might take the information if the client's not ready. So it helps officers tremendously to go ahead and be able to put an advocate there and for us to provide those services.
Fantastic. It's such an important service you're providing. Thank you, Jen, for sharing. Next, we're going to go to behavioral health with Telecare Corporation in San Diego, and Tim Graves, who is the Director of Special Projects and Enterprise Architecture, is going to share with us a bit. Hello, Tim.
Hey.
How are you doing?
Good evening.
Thank you so much for joining us. So, going to go through the same questions with you. If you could tell us a little bit about the program and particularly the scope, what kind of assistance are you providing?
Yeah, absolutely. Telecare is a large behavioral health provider. We operate over 150 different programs. And so far, only one of our programs is a mobile crisis response program. So we're now another tool in the toolkit for emergency services in the county of San Diego. We provide services across the entire county of San Diego, roughly 3.3 million people. To kind of put it in perspective, that's about 2 Manhattans. We operate with about 90 FTE. Our mobile crisis response teams fit a common pattern that you're seeing in a lot of other metropolitan areas. So it's a team that's dispatched into the community and provide crisis intervention services in lieu of law enforcement or EMS.
So how does this work? How do they decide, how do people get in touch with your mobile crisis response teams?
Yeah, there are 2 channels that people can gain access to the services we provide. The first is through San Diego's Access and Crisis Line. This is a crisis hotline. So we'll get referrals from them, as well as directly from the local law enforcement jurisdiction's emergency communication center. So a law enforcement dispatcher can call us directly if they're speaking with someone that's called either 911, or if an officer runs across a client that is in need of crisis intervention services, they can then request that additional resource and they'll contact us.
And so they contact you, have a centralized call center?
Yeah, so we have a virtual call center that we've stood up in San Diego. It's staffed by a blend of dispatchers as well as licensed clinicians. So what we do, they'll either, forward the reporting party to our call center, and we'll begin our triage process. Additionally, what we provide is if it's suitable, if the nature of the call is suitable, we'll actually provide kind of telehealth services using a licensed clinician to help provide some over the phone intervention services where possible.
So when you determine to send somebody out, the dispatcher, gets the information and then does triage, as you mentioned. When you decide to dispatch a mobile crisis response team, how does that work? Are you sending individuals? Are you sending teams?
We're sending teams. They're actually pre-positioned throughout the jurisdiction to minimize response times. We currently operate 7 units. It varies a little bit depending upon the load. To kind of paint a picture for you, the team's comprised of a licensed clinician, a case manager, and a peer support specialist. kind of with lived experience with either mental health, substance use, or other behavioral health challenges in life. So the team will get dispatched from our call center. We use the Beacon service to coordinate that dispatch, in addition to other technologies like we operate a FirstNet push-to-talk network that enables kind of real-time communication between our units and our comm center. You know, sometimes even our dispatchers, like in the early morning, will be working virtually from their home because our virtual call center enables us to have kind of remote workers as well.
Fascinating. So they get dispatched through the Beacon platform, and then you also supplement that with this FirstNet push-to-talk. Why did you choose the push-to-talk phones over radios? So,
you know, the cost of a radio can be prohibitively expensive. You know, I have a background in fire and EMS, and, you know, my radio cost about $10,000. And if you were to outfit, you know, 90 employees, or, you know, roughly a quarter of that's what you have on staff at any given time, it's a significant investment. Additionally, you have to kind of bring your jurisdictions on with you, right? So we serve the entire county of San Diego. They have a vast network of radios and a variety of protocols to deal with that. Additionally, our providers are, you know, behavioral health providers. They're not necessarily trained in the proper use of a radio. And really, I mean, to paint a picture, from the point we sort of received the contract from San Diego to the point we stood it up was roughly about 4 months. And it wasn't a lot of time to, you know, make a capital purchase of radios and coordinate with the county radio authority to, you know, stand that up. So it's really that combination of kind of real-time push-to-talk FirstNet phones with the information that we can convey in Beacon that really kind of paints a picture for the responders, so that they know what kind, you know, the nature of the environment they're walking into.
Yeah, I think that this is really fascinating for a lot of people, because we talk to a lot of groups, and they sometimes are understandably under the impression that if they're plugging into the local 911 call center, that 911 is going to give them the same radios that they give to police, fire, and EMS. Mm-hmm. And that's, as you're explaining, certainly not the case. So that's really helpful to understand. So when they get on scene, what types of help or assistance are they providing to people who need it?
Yeah, absolutely. You know, the number one priority is, you know, ensuring the safety of the client and the scene. And that was really a little bit of a shift. You know, working in EMS, working in fire, you know, we're taught from a very early stage in our training that, you know, managing the scene is critically important. And it was a bit of an epiphany when we were kind of doing our training with our staff, when we said, look, you're now part of the first response team, right? Like, you're integrated into this system at this point. We're no longer sort of like a behavioral health provider that sort of provides niche services in, you know, let's say for people living in the community. You're really part of this larger system of care that exists. And that was, I mean, everybody's eyes, you know, kind of open really wide when they realize that they're now first responders.
I believe it. How have you been received by the traditional responders, fire, police, EMS?
This was actually something that we invested a lot in really early on, in making sure that law enforcement, fire, and EMS were at the table with us as we were developing our crisis response plan for San Diego County. You know, our program came through the Department of Behavioral Health, which kind of reports up to that larger system of care. but we wanted to make sure that they had a voice in sort of, how we interacted, and made sure that we invested in that relationship up front so that we could coordinate response appropriately.
And so I'm assuming, I mean, myself as a former San Diego County paramedic, this program seems to me long overdue. I take it that they're very happy to have you as a part of their system now.
Yeah, absolutely. In fact, we've already expanded the program once, and I think we're looking to expand it again, as well as expanding into other counties, other states.
That's fantastic. So if you could share a little bit more about what type of volume, how many incidents are you responding to on average per month, we'll say?
Yeah, I don't have the per month number. I do know that since the program opened, we've responded to approximately 1,000 crisis response. We respond in lieu of law enforcement, provided that the environment's safe and we don't need law enforcement to secure the scene for us. We prefer to actually kind of operate independently because it makes space for a more meaningful engagement with a client.
Absolutely. So how does it end in terms of when do your responders know that the call has come to a conclusion? What is the objective they're going for?
Yeah, it varies. There's a couple of outcomes. The most important outcome is that we, prevent adverse events from occurring by simply showing up, or by being there instead of law enforcement. All of our providers are trained in CPI. All of our clinicians, licensed clinicians, have a license, so they've gone through rigorous training in de-escalation and things like that. In terms of outcomes, sometimes we might link the clients to other levels, lower levels of care. So we might link them to, one of our other programs that we have down there, which provides wraparound services for people with severe mental illness. Perhaps, they need some additional crisis intervention, in which case we'll transport them to a crisis walk-in clinic. There are a number of crisis walk-in clinics in San Diego, so we'll actually do the transport ourselves. In some cases, they're a danger to self and danger to others. So in California, we have a 5150, and our licensed clinicians will effect a 5150 hold on them so that we can compel them to get to someone that can provide additional care.
Fascinating. Thank you so much, Tim. Really appreciate it, and just hats off on the fantastic work you're doing.
Yeah, thank you.
So next, we're going to talk to folks from the Connecticut Harm Reduction Alliance. Is Alex on the phone? Tani, did she make it?
Yes, I did.
Hi, Alex. Excellent.
My email got caught up in our last name change, like the last part of our email got, I guess, changed. So it got stuck in my old GHHRC one and it got mad at me. But I figured it out.
Well, so glad you made it. You have a really fascinating program there in Hartford, Connecticut. And this has been a really special program to be a part of and to watch. And I'm sure our listeners will be equally impressed. I'm wondering if we could just start and you tell us a little bit, what are you addressing through your crisis response teams?
So what we're addressing specifically are overdoses, specifically for opiates. Ideally, the realistic part of it is that we're responding to drug ingestions or unconscious folks. So how it comes in is kind of varied. Sometimes we might get someone calling in for like a drug ingestion where they're worried that this person is going to be a harm to themselves or others. But most of the time it's specifically for an unconscious party that they think is a drug overdose. Okay,
so there are a couple ways that you find out about this. And could you walk us through, let's say somebody calls you directly, how does it work?
So yep, so we have two different ways of how we do it. So if someone calls us directly, that's why I mentioned the drug ingestion, because if people have called us directly, sometimes they're calling because an overdose is happening in real time, or they're worried that it's about to. It's kind of like this quasi alternative to the police, where if they're calling us directly, they might be afraid to contact 911. So they're trying to get to us first. So they call us on our phone number. We have a cell phone that's specifically dedicated for this line. So if that one rings, it's myself or the other dispatcher answers. You know, we introduce ourselves as the dispatcher, and basically kind of like a regular 911 operator, we try to get basic information such as location first and foremost, you know, like what the situation is and what we can dispatch out. So if someone's calling me and saying it's a drug ingestion, or like, let's say someone has consumed like PCP, you know, that's something where like Narcan isn't going to work. They might be in the road, things like that. So we might dispatch someone out in order to help with kind of like a de-escalation, as we're more accustomed to working with folks in those altered states. But it's mostly to specifically go out and try to get there before EMS and 911 for an overdose reversal. So we will reverse the actual overdose. So the first one is they call us, we get their information, and we immediately dispatch out folks, and we have a broadcast system for the city of Hartford. And then we stay on the line with them and kind of like close out with that person specifically if they're calling the line directly.
Okay, and so that's if they call you directly, because as you said, some folks don't feel comfortable calling 911, so they call you and then you respond, and eventually 911 does get contacted.
Yes, we do. We contact 911 if they haven't contacted 911. Because
right.
For us, we are not responding as medical professionals. So I'm not going to respond like an EMT or paramedic and try to pretend that I can come upon, let's say someone's not overdosing. If I'm responding to a medical emergency, I want to make sure that those who are qualified to respond also come with me.
Right. So it's more about having a friendly face on scene and someone with lived experience.
Very much so, because I mean, it's going to be probably over like 90-something% of our responders are folks with lived experience with drug use, specifically chaotic drug use at that.
Yeah. And so how does it work with the 911 scanners? Because that's a unique approach as well.
Yeah, so for us, you know, overdoses are notoriously not called in. So historically speaking, and just for those of you who maybe aren't as familiar, a lot of drug overdoses occur where no one's calling 911. You know, where those who are in the area are responding with Narcan if they have it. You know, like luckily, we have a lot of folks that have Narcan in their hands. It's unfortunate that everyone has to have it, but a lot of times people respond. You know, people who use drugs with one another are going to respond and have Narcan, and depending on the situation, aren't going to call 911. So we listen to the Hartford City Fire Department scanner as well, because fire department gets all calls. So that is a lot easier. And what it showed us is that we show up, oftentimes we're showing up before EMS or at the same time as them. So that's been really, really interesting. And then you get to know different areas of the city. I mean, for those of us who work in this field, we know our city really, really well. So we know areas that are kind of more prone to have maybe, let's say, like public overdoses and things like that, due to just where they're geographically located. So you get to kind of know that as you're dispatching over time. Like, okay, if I'm hearing an unconscious party and it's at, you know, 172 Washington Street, I know it's most likely an actual overdose because a lot happened at that address and at that apartment complex. So we respond if we hear unconscious party, or sometimes they'll say overdose, but depending on how people call it in, we're the ones who actually dispatch and go out. So that would be in conjunction with fire and EMS if they arrive, or if we get there before. But they know us all really well by now, because we also worked with the local like fire department as well as police department when we were starting this, and then just having everyone introduce themselves, because it looks weird when you come up on scene and like EMS are there and you're the one who's there, or like we pull up in a car with it. So we all wear our badges and identify ourselves, and it's gotten a lot easier since then.
And that's actually part of the reason, and sorry to jump in, you know, initially it wasn't that easy. So there were a lot of subsequent conversations with both fire and EMS, because initially they weren't sure who we were or why we were showing up. But, once we were able to get a lot of those details worked out, and actually, as a result of those conversations, started Hartford's opioid task force. But then also we have people who are, will do a both and. They'll call 911 and they'll call us because they know we're, generally somewhere in one of those areas, Capitol Avenue, Broad Street, Park Street, Upper Albany. We'll get those phone calls as a both and. And in many cases, as Alex alluded, we may have somebody already out in the field, and it's a whole lot easier to get them there. So that's been a huge piece.
That's actually perfect timing too, because our drop-in center on Albany Avenue, Mark called this morning, we had an overdose that was right around the corner. And because of where we're at, a lot of people already know why we're here. So anytime there's one in the area, people will come to the drop-in center, say someone fell out, look for Narcan, and we respond both with that person. We have another staff person that calls 911. So that happened just a few hours ago, where someone came into our establishment and said, I need Narcan. So myself and another staff person ran out with him and chased, followed him around the corner to where someone was overdosing while our other staff called 911. And then we had our dispatcher that was on, so she dispatched it out, and we got to respond to it. So that way it's all logged within there. And this person was already Narcan and put into a vehicle by their friends to be brought to the hospital before EMS or anyone even arrived.
Yeah, so this is a really awesome example of grassroots from the ground up, and your both and approach, I think, is really, really important for people to understand that this is not an alternative. This is a supplement, that you are doing it alongside 911, because let's be honest, that 911 isn't able to get to overdoses as quickly as they should all the time. So,
well, they were actually, when we started, when I started first having these conversations with EMS and fire, they wanted to know, how were we able to get on scene so quick? How are we able to respond quicker than them in many cases? And, just basically letting them know, we're out there, we get calls, and the way the system is set up, it will dispatch whoever is closest to that scene or whoever can respond. So it actually benefits. It benefits the people we serve. It saves lives.
Yeah. So as opposed to the other two, to SafeNest and Telecare, where they are designating specific responders to go, you're doing more of a, we'll call it a crowdsource approach, where you're blasting an alert out to a large number of your street outreach workers. Is that correct?
Yeah.
Yep.
So tell us just a little bit how that works. You send out alert to everybody, and then what happens next?
So, well, it's actually changed a bit since you all have made upgrades, which I sincerely appreciate for everything that's happened with it. So we worked with Jason specifically to kind of try to figure out how many people did it make sense for it to broadcast to. So Beacon has that broadcast option. And so what it is like when we input it, we have a 3-person cutoff is how we decided that kind of worked best for us. And Beacon itself already will pick up on the GPS location of our dispatchers. So what I really like about Beacon now, especially, is how it'll say how far people are from it. It'll even pop up the directions of how to get to that location through the app as well as on the web. So it gets dispatched out, and then whoever responds quicker, those are the two that get sent, those 2 or 3 folks are the ones who then get sent to the actual location and then move forward through the process of the actual app and responding to it.
So that when they get on scene, if they're there before fire EMS, they administer Narcan. If they get on scene after fire EMS, are they of no use, or, what do they do?
No, so what they do is they engage the folks around them. So they're going to, depending on where they are, unless it's like some sort of like internal apartment inside of the building we can't get into, our folks always engage anyone in the surrounding community. It's a really good opportunity to talk about overdose recognition, as well as like how to respond, and just getting more people aware of Narcan and how to get more Narcan to them. So oftentimes you'll engage the family, EMS, or maybe just those around the area. And it becomes a lot easier both for EMS to know us, but also for the community to know us more. And, you know, if the community already knows us, then it gets a bit easier. So like, for example, the OD that happened was outside of a house. And we ended up giving 4 kits of Narcan to the house because they have a lot of people who use drugs who frequent that location. So things like that are really, really helpful, even if you aren't the one who actually administers the Narcan.
And then sometimes you just stand down. You stand back, and if they need you, they'll say, hey, you know, do you know this, or do you know this person? Can you give us a hand? Or maybe not. Either way, you know, we are not there to interfere. You know, they're the first responders, and we just provide support anywhere we can.
So this is really interesting. My experience when I was working on the ambulance was that there were 3 choices for someone who had just had an overdose reversed. You could take them to the hospital, which oftentimes they didn't want to do. The police could take them to jail, or we would put them back on the street, offering no support services whatsoever, largely because that's not what we were trained to do. That wasn't within our scope. So what does Connecticut Harm Reduction Alliance do for someone who refuses transport to the hospital?
So I'll start with that. So if people are refusing to transport to the hospital, this is where I think like us being there is exceptionally helpful, because when you have Narcan administered, it's only temporary, and you have a really high probability of falling back either into an overdose, or you're feeling sick because you're in precipitated withdrawal. You might try to use, it's not going to work. You know, it's a really high risk situation that someone's in. So what I really like about us having responders is we're able to engage the party and say, you know, talk about risk reduction practices that they can engage in, what they can expect until the Narcan wears off and after it does, and getting them Narcan, getting them linked to services if they want. You don't want to overload someone with a whole bunch of resources and stuff after they just survived an overdose. But it's helpful for us because we're not the person with the sirens and the lights that shows up in a uniform. Like Mark said, it's more of a familiar face already. So I'll be honest, that really does it decreases a lot of barriers to getting folks help. So yeah, it's really just engaging the person, seeing where they're at and what they might need from us, and what best we can to keep them safe in them surviving that overdose.
Fascinating. So
that's what I forgot to say was the care package. I'm glad I remembered that. We had put together at first for emergency departments, but then also for responding to beacon calls, overdose care packages. So what happens is a lot of people get transported to the emergency department where all of their stuff is taken, seen as bio waste, and then they're left with absolutely no supplies whatsoever. And then when they leave, they have no supplies, depending on what time it is. They have no access to get more supplies. So you have a super high risk of someone that might engage in higher risk behaviors than they normally would because they're in a state of desperation. You know, this is where you're seeing folks who might share a syringe or, you know, use a found cooker or something like that puts them at higher risk. So we put together these overdose care packages that not only had Narcan, but that had resources, had syringes, had cookers and cottons and ties. So that way, just in case, if you're choosing that, you know, like, you know what, I'm not ready to, you know, stop my use altogether from this experience. If you choose to continue use, I want you to have your own stuff. It's all about harm reduction. How can I reduce these harms? So that is something else that we were able to provide.
Right. So you're providing these ongoing support services that police, fire, and EMS can't. So last question. I know you're a smaller outfit and you guys are spread so thin in all the different services you provide, but when the service is running, how many responses do you have on average, let's say, per week?
So when all pistons are firing, you know, like we have folks that can dispatch, it really, I'm going to say part of it depends not just on current drug trends, but also things like weather. Because with weather, you're going to have more public overdoses, like how I mentioned before, how a lot of these happen behind closed doors where no one's even contacted and nothing's called in. It tends to be, you know, like in these warmer months when you just have more people outside that were receiving more calls. So that's one aspect for us that it depends on, as well as current drug trends. So for example, the other day, I had a cluster of overdoses that we dispatched out. that were about 3 overdoses that I dispatched out within about an hour time period. But I also didn't dispatch out some different drug ingestions where people are having, they were conscious, but maybe they were in the road, things like that, that we're not equipped to respond to for safety purposes. But stuff like that, where you might have quite a few more depending on the batch. So for per week, I would say if we have everyone on, you're looking at about maybe, unfortunately, anywhere from 2 to 6 calls a day.
Right.
That you would have it for like during our hours of overdoses. And for those of you that don't know Hartford, Connecticut, we're not that large of a city. So that might sound like a small number, but that's quite a few for those that are actually being called in and then dispatched out and responded to. So
Hartford's what, 125,000 people?
Oh my gosh, I feel like I have to look it up. Maybe Mark knows it and he'll tell me
That's
before
right.
I have to look it up.
That's correct, Jason.
It is? Okay, I was like, I hope you are, Mark will pop it and tell me. Yeah, it's not that large.
No.
And that doesn't account for also, though, people who come into Hartford in order to get services or to get their products that they're then going to go home.
It's 7 square miles.
7 square miles.
Yes.
Wow. Okay.
I work here and I didn't even realize it was that small.
Yeah. All right. Well, thank you very much. Again, such an impressive program and a truly life-saving service that you're providing. We really appreciate your taking the time to do this. So that's the end of the features that we're doing on the different services. But now what I'd like to do is talk about how can you apply this to your own crisis response team, right? How are you going to go about setting this up? And so we're just going to go through these 6 questions and give you some ideas. Again, we're not necessarily here to endorse any specific solutions. You've got to make it work for how you can. One of the things that people don't realize, at least in the United States, is that there's a saying that if you've seen one 911 call center in the United States, you've seen one 911 call center. Everybody does it different. Everybody figures it out with the resources and the budget and the supplies that they have. And so we're here more to give you a methodical way to figure out what technologies you're going to need to make it happen. And so the first is, again, the scope. And, what types of crisis will your service respond to? There are 3 things in general you should take into consideration. The first is the urgency of the service you're providing. Are you dealing with life-threatening crises, like what Connecticut Hartford Harm Reduction Alliance is doing, or are you doing non-life-threatening crises, right? If you're doing life-threatening crises, then you're going to need something that is going to be reliable and real-time in terms of communications. This is what Tim was talking about in San Diego with push-to-talk radio, push-to-talk apps versus radio. You need to have a way to maintain reliable and real-time communications with your responders. If you're doing non-life-threatening crises, then you may be a little less vigilant, but Tim's a great example of what they're doing in San Diego is that the assumption is that these are non-life-threatening crises, but when responders get on scene, they may actually find out that this isn't, the information that they had when they were dispatched isn't exactly what they're looking at now. Maybe things had changed, or maybe there was some miscommunications during the dispatching process. I can tell you when I was working as a paramedic, when we were doing 911, my mentor always told me, don't believe what dispatch tells you, not because they're not reliable, but because things can change. So you've got to keep it in mind whether you're dealing with life-threatening or non-life-threatening, or if something can go from non-life-threatening to life-threatening. The other thing you want to consider is availability. Are you a 24/7 service? Are you doing business hours only? Or is it per diem, meaning as available? If you're a 24/7 service, like SafeNest and Telecare are, then you're going to need constant, reliable communications with backup plans, right? Because if you go offline, then you're in trouble, and so are the people that you're serving. If you're business hours only, which is much what Connecticut Harm Reduction Alliance is doing, they're responding as they're able, and that's generally through business hours, right? Now they're doing it as a supplement or alongside 911. So if they don't respond, they know that 911 is. Their goal is to get there before 911 does, but they're doing it on business hours when they're available because, frankly, they don't have the staffing or availability to do it 24/7. Like we said, this is very much a grassroots program, so they're making do as they can. If it's a per diem service, that's another story. A lot of people don't realize this, but New York City EMS is run by the Fire Department of New York. However, people don't realize that New York City actually has a lot of volunteer ambulance services, especially in the outer boroughs. And what that means is that these volunteer ambulance services, when their volunteers are available, they'll get on the ambulance and they'll listen to the radio, just like Connecticut does. They listen to the 911 scanner, and if there's a call in their area, what they say is they'll jump that call. It's totally acceptable because they do it as they can, but that's because FDNY will respond no matter what. So they're a value add to 911. You can do the same. If you're only available certain hours, as long as you're adding value to the existing infrastructure, then that's totally acceptable. The other thing you need to consider is volume. Are you going to do a medium to high volume? And we define medium and high volume as simultaneous incidents, right? More than one incident is happening at a time. If that's what you're doing, then you're going to need a purposeful technology solution. If you're doing low volume, like one incident at a time, or you only have a handful of responders, then these off-the-shelf technologies are more acceptable. What I mean by off-the-shelf is something like WhatsApp or Facebook Messenger or Telegram, these chat apps. They are used all over the world by response teams, but they have limited effectiveness because they were not designed for emergency response. And again, if you're low volume, you have a handful of responders, you're doing one incident at a time, and you don't require documentation, then these chat apps might be all that you need. But if you're doing higher volumes, you have a lot of responders, or you're scaling, then you need to be looking at a technology or technologies that are much more designed for what you're trying to do. Next question is access. How will people call for help? And again, there are multiple ways to do this. And the three organizations we just talked to gave different ways that they're doing it. The four that we break it down into is a standalone call center where they are using an access number to call directly. And what we mean by access number is what's the phone number that they call to access help. There are two types of numbers. There's long code, which is like the 10-digit number that you have for your own phone or for the office. And then there are short codes, which is less or equal than 6 digits. The issue about a standalone call center is that it's going to require you to manage the setup and maintenance by yourself. So using simple technologies is going to help go a long way. Or Telecare is a great example where they have a dedicated person who's very much up to speed on these technologies and can bring them together and keep an eye on them to make sure that they're all working together. A standalone call center also allows you, you decide, you call the shots on how things work. So you have that managerial autonomy. An integrated call center is a different story. And that's usually where you're plugging into, let's say, 911 or 311 or 211, whatever it may be. And what happens here is that you're using their call center, to take the calls. So people will call them. And then if you're going to be dispatched, they'll do it through their call center. In this case, you likely won't need your own dispatchers. You'll use their dispatchers. You may need to provide the dispatch technology to them to alert and coordinate your responders. Because again, if it's 911, they're not going to hand you their radios, most likely. But it's also going to take away your managerial autonomy, right? You're going to be playing by their rules. If it's an established call center, then they have their protocols. They will tell you how things are done, and you're going to need to figure out how you fit in with that. Another option is a relay call center, and both SafeNest and Telecare are doing a version of this where they may call 911 and then they decide to kick it out to your call center, right? They have their criteria for when they will pass it on to you. And in this case, again, you're relying on the established access number, so 911, but then you're going to have to work with them to figure out when they pass it on or relay it to you and when they don't. There's less managerial autonomy, meaning they're going to be deciding when it gets sent to you and when it doesn't. But There are ways to work around that if that's not a good thing, which is that you can also set it up like SafeNest and Telecare did, where people can contact you directly. So there are multiple ways to get access, and there are multiple models. The mobile call center, this is very much what Connecticut is doing. They can dispatch from their office, but if they're out on the street working with their beneficiaries, with people who need help, then they can get calls directly to their phone, and using the right dispatch technology, in this case, they're using our Beacon platform, they can create incidents and send out alerts to their entire team directly from the phone in their pocket. So it's kind of a mobile call center in that the call center goes wherever you and your phone go. This doesn't require fixed facilities, but you're relying on personal phone numbers, right? The office number, your personal number. So it's going to be a lot harder to set up like a short code or a simple to remember number. And in this case, you can use off-the-shelf technologies or low-code tech, because the whole point is to use whatever's in your pocket. So that's the second question of access. Then call handling. This is the crux of the whole operation. This is where supply and demand meet, and how dispatchers figure out what the demand is, and they decide what the supply is going to be to get help to them. So the first step is interrogation. And I don't, interrogation, not in any kind of negative connotation, just how do you find out what the need is? There are two ways you can do this. There's what we call manual interrogation, which is you decide what questions you are going to ask the caller, right? And Alex from Connecticut mentioned that they are very much following the script of a 911 dispatcher in terms of figuring out first what the location is, the nature of the emergency, but they decide what questions need to be asked. Whatever questions you decide to be asked, just make sure that you're doing it based on evidence and that you're using protocols, right? So that there's a script. 911 dispatchers follow scripts. Whenever you call 911, you are talking to someone who is reading directly from a script. They are not making up the questions. They're not ad-libbing. They are following a very regimented script. So it's a good idea to do the same. And this is to cut down on variation in terms of finding the right information. A lot of times you will hear about something called interactive voice recording. Anybody who's ever called up a customer service hotline has had experience with an IVR, where as soon as the phone is answered, you hear a machine or computer saying, if you want to talk to person X, push 1. If you want to talk to department Y, press 2. These are out there, and there are all sorts of companies that offer them. If you're doing crisis response, we would encourage you not to get involved with these. If it's a crisis, nobody wants to be sitting there pushing buttons and listening to recordings. They want to be talking to a human voice who can empathize with them and get directly to the matter at hand. However, if you're doing non-life-threatening crises, if you have a huge operation, this may be unavoidable. It may help you be more efficient, but we would definitely recommend against it if you are doing life-threatening crises. Also, if you're going to set up an IVR, just be aware that you're going to be needing a developer to help you with that. It may be a limited number, it may be a lot, but generally speaking, you're going to need a software developer to help you set that up and maintain it. So once interrogation is done, then it's triage, right? How do you determine which resources are available and which ones need to be sent? So dispatchers, this is where they become so important. They are the bridge between demand and supply, and they're going to need a way to keep track of what resources are available and the scope and type of resources that they have. Are they offering different skills, training, supplies? Tim from Telecare was talking that they have a multidisciplinary team, right? So that they have teams of 3 and they all have different skills and training. And that's really helpful if you can do it that way, because then whatever team you send, they've got the people they need. But it may be a different story for your crisis response teams where you don't have that number of staff, or you're responding to a bunch of different crises. So whatever the case is, your dispatcher needs to be able to know who's available and what they can provide. Another thing, we hear this all the time, and we just want to make it clear. This is what you're doing is not Uber for crises. People look at Uber and Lyft and they're like, it is so easy and smooth and it works so well. And we want to remind you that taxi services are not crisis response, right? They have a lot in common, but they actually have a lot that isn't the same. And that is the big difference between requesting a taxi and requesting a crisis responder. So just don't fall into that trap of thinking that the tech is going to do everything for you like it does in Uber, right? If somebody pushes a button on Uber requesting a taxi and it's the wrong location, then somebody doesn't get a taxi. You know, that's not a big deal. But if you're trying to have the tech do everything for the callers and the responders, and the location is they push the wrong button on the map or whatever it may be, that's a big loss, right? There's a lot more at risk there about getting these small things wrong. So don't think that what you're doing is Uber for crisis response. It's not. It's much more complex and involved than that. So once you've figured out what resources you need and who's available, then it's the dispatcher's responsibility to alert the resources and assign the ones that are needed. And there are two ways that this can happen. And we've talked about both of them today. The first is designation, right? This is where a dispatcher decides who's going to go and who isn't going to go. And this is the traditional way that dispatching happens in 911 call centers, right? The dispatcher acts as the chess master, moving the pieces around the board, or like, you know, a puppet master, and they're pulling the strings of the responders who need to go and who stays. And this approach of designating responders is most useful when the dispatcher knows which resources are available. However, as we were talking about with Connecticut, another way is crowdsourcing, which is more of a first come, first serve approach. And this is most useful when the dispatcher doesn't know who's nearest or who's available to help. And what Connecticut is doing is that they're sending out a blast alert to all of their responders. And then through our Beacon platform, there's a way, automated way, that it decides who's closest and who isn't. And this is, again, much more useful when you don't know who's closer or who's available, and you don't have time to sit there and figure it out by calling people up or notifying them one at a time. You got to figure out which way are you going to do it. Are you going to designate specific responders, or are you going to crowdsource the nearest responder and get the technology that's going to help you do that? Next is the response. So how will responders be coordinated, right? So now we've alerted the responders and we have specific responders assigned to an incident. Now we need to coordinate them, right? And this goes back to what I was saying before. If you've got a small volume job, you know, a small volume service, when you're doing one incident at a time, or you only have a handful of responders, then these steps here, you can do it just through a chat group, no problem, because it's easy to keep track of. But if you have a larger number of responders, or there are multiple incidents going on at the same time, then a chat messaging app isn't going to do you much good. It's just going to confuse things. Let's say that you're now coordinating your responders. How do you coordinate them? Well, there are at least three things you need to keep track of when you're coordinating your responders. The first is, are they en route? Are they on their way to the incident? Then you need to know, when do they get on scene, right? So they've arrived at the location, they've located the patient or the victim, whoever it may be. You need to know that they are there. The last step is completion. You need to know when they're finished. And that's just so you can keep track of who's available and who can go to the next incident and who can't. These other two steps here in the middle, additional resources and transport, this depends on the service that you're providing. Additional resources is important in case your responders don't have enough supplies, or they find themselves in a situation where they're in over their heads. They need law enforcement, they need ambulance on scene, so they have a way to request additional resources. And then if they do transport, then you're going to want a way to be able to track that they're transporting when they leave the destination and when they get there. So at a minimum, you need to be able to track when your responders are en route to the location, when they are on scene, and when they are completed. And depending on your service, you may also need to track if they need additional resources and if they're transporting. So depending on what type of service you are providing, then this is going to help you figure out whether or not the technology you're looking at is the right one. Then intervention. And again, we're not talking about actual interventions in terms of, are your responders carrying Narcan, or, you know, are they providing the right type of counseling on scene? From a technology perspective, what we care about in the intervention stage is how you are documenting it. And this is really important. Again, going back to Connecticut, where they kind of had to prove their merit to the established response system, there's ways that you can do that. And documentation is going to help you go a long way in proving your worth and your value to the system. There are 4 types of information that you should be documenting. I'm not going to go through all of them here, but, you know, information about the incident, information about dispatching, your response times, and if possible, a narrative, keeping in mind that you're not documenting HIPAA protected information, confidential information, if you don't have the right technology to do that. You know, of these 4, the number one way to prove your effectiveness as a crisis response team is response times. Specifically, how long did it take you to get on scene? If you look at the evaluation or assessment of performance for EMS, fire, and police, the number one thing they're asking is how quickly did they get on scene? If you look at an ambulance service, they oftentimes have requirements where in urban areas, 90% of their responses, they have to get on scene in 8 or 10 minutes or less. Depends on the city, depends on the contract. But generally speaking, the number one way an ambulance service proves if they're doing a good job is their response times. Same thing with fire departments, same thing with police. How quickly can they get there? They are emergency responders. The best way to prove that you are able to do the job is to get to the emergency quickly. So these are the things you need to be thinking about when you are setting up your technology, is can you document these different variables? Finally, how will you know when the objective is met? And this is pretty straightforward. What are the signs of successful response? We kind of look at it in 4 ways. Was the right responder sent? Were they sent to the right victim at the right location? Did they get there in time? And did they deliver their intended value? If you have a yes answer to all of those questions, then you know that your objectives have been met at a minimum. And again, this should be illustrated through the technology that you're using. So those are the 6 questions you want to go through in order to figure out what technologies do you need. Now, just to get into the weeds a little bit, I've put together a little bit of a diagram here of different technological solutions. And again, this is not a comprehensive list, nor are we endorsing any of them specifically for your response team. And I'll even say that we're not specifically endorsing our technology, Beacon, because there are some response teams that Beacon isn't needed for. If you don't have a lot of responders, if you don't have a high volume of incidents, and you don't care about documentation, then WhatsApp, Telegram, Signal, whatever the messaging app could very well be exactly what you need. If you have a higher volume of incidents, if you have a larger number of responders, if you care about documentation, then you're going to have to look at other solutions. We have experience with Cisco and Twilio. We've seen them, we've implemented them. We know that they work very well for taking calls in, for managing call centers, for doing triage. A lot of them stop, though, at the dispatch part. And when you get to dispatching, then you're going to need something that was set up to do dispatch. They're often called computer-aided dispatching tools, a CAD, but they can be as simple as a radio. A radio provides real-time communication, so you can talk with a lot of people, one person at a time. But the downside of radios is that the good ones are very expensive, and radios don't document anything. If somebody says, I'm en route, the radio doesn't take a timestamp of when they said they're en route, or when they said they're on scene, or when they're finished. So you may have a radio for real-time communications, but you'll still need a way to timestamp stuff and document what's going on. This is very much why we built Beacon. We built Beacon because a lot of the computer-aided dispatch technologies that are out there and being used in 911 call centers are very old. They call them legacy technologies for a reason. They were originally built in the 60s and 70s, and they've been tinkered with ever since. And they've obviously gotten more sophisticated, but most CADs in 911 call centers were built before mobile phones became the norm. And so these days, the CADs that are out there, they're targeted for 911 call centers and specifically municipal budgets. So a lot of crisis response teams can't afford or don't need the CAD legacy technologies that are being used. And that's specifically why we built Beacon. With that said, Beacon has its limitations in terms of real-time communications, radios, or there's an app that a lot of people use called Zello that allows for the real-time communications. But again, neither Zello nor radios are documenting anything. They're not keeping track of responders. They're not showing you who's where and who's available. They're just allowing people to speak freely back and forth. Different crisis response teams have different needs, but we definitely, all the partners that we've been talking to today have been using our dispatch technology Beacon, and it has been successful for them, and we're working with them to always make it better. Just to give a little bit more about Beacon, there are two parts to it. There's the Beacon dispatcher and there's the Beacon responder. Beacon dispatcher can be used on any computer with an internet connection, and it allows you to keep track of your responders, to create alerts, to follow them on maps, to create maps that have custom icons if that's what you need to show different locations. And it does all the reporting. The responder, we do it both through a mobile app, which allows you to either designate specific responders or to crowdsource, like we were talking about, broadcasting alerts with certain permissions. It allows you to monitor the location of other responders. It also has the end-to-end coordination, like we were talking about. So are you available? Are you en route? Are you on scene? Additional resources? Are you transporting? Are you complete? And it also has in-app and SMS chat. The other thing that we do is that if people don't have a smartphone or they don't have internet, they can switch over to the SMS version so that they can receive and reply to alerts via SMS. If you'd like to learn more about Beacon, you can come to the website here, trekmedics.org/beacon, or you can send us an email. Here's some contact information if you'd like to reach out to anyone. And thank you very much for everybody for joining us. It's been a real pleasure, and we hope to hear from you about what you're doing and if there's any way we can help. Thanks very much.